Okay, let's deal with chest pain. Okay, uh, whenever a patient comes to our emergency department with chest pain, we have to rule out the life-threatening causes first. Okay, if we do not rule out these life-threatening causes, then that can kill our patient within minutes to hours. So, what are the life-threatening conditions we have to rule out? Okay, these are the 6 conditions. Okay, first of all is acute coronary syndrome, also known as myocardial infarction. Next one is aortic dissection. Okay, aortic dissection. Next thing is pulmonary embolism. Tension pneumothorax. Tension pneumothorax. Pericardial tamponade. Okay, pericardial tamponade. Esophageal rupture. Okay, esophageal rupture, also known as Borahave syndrome. After we rule out these 6 things, then uh, this then our job will be so easy, and our patient won't die immediately, and we'll have time to think about the patient or call for follow-up and do examination of the patient. Okay, so how do we do the initial stabilization or initial conclusion of the diagnosis? Okay, first of all, we have to do initial assessment. In initial assessment, obviously, for like any other cases, we have to do ABC. Okay, airway, breathing, and circulation. How to check for airway? We have to look if the nasal or the airway, we can take air from mouth as well if nose is obstructed. Okay, and these things are intact or not. Okay, if there is any secretion, if there is any foreign body, okay, if anything like dental these fractures or this thing dentures, okay, artificial might be, or any fracture of denture, we have to deal with that, and we have to remove this if needed. Okay, and talking about breathing, okay, we have to look if the patient is spontaneously breathing or not. If the patient is not spontaneously breathing, then we might need to intubate that patient. Okay, and okay, and if that is spontaneously breathing, then we have to look the type pattern of breathing. Okay, and shallow breathing, deep breathing, we have to notice that as well. Okay, and if for spontaneous breathing, if a patient is doing spontaneous breathing or not, we can look at the nasal flaring. Okay, nasal flaring, chest rise. Okay, this thing we have to notice. Okay, after that, the next thing will be circulation. Okay, how to deal with circulation. Circulation basically means what is the blood pressure, what is the pulse. Okay, and if the patient is in shock, then we have to treat shock first. Okay, after looking at the airway, breathing, and circulation and dealing with that, if immediately needed, we have to move forward. Okay, when taking BP, we have to record BP in both arms, because in case of aortic dissection, there will be difference in the blood pressure of both arms by about 20 mmHg. Okay, and it is one of the important cause of chest pain presenting to our emergency department. And pulse, looking at the pulse, we have to look the rate, rhythm, and more importantly the synchronization. Okay, synchronization is there or not, radial and radiofemoral. If there is any delay or they are synchronized, we have to notice that. After that, SpO2, respiratory rate, and temperature of the patient. Okay, and after going towards the ABC and vitals, the next thing will be focus history. Okay, we have to look at the Socrates. So the history of the chest pain is basically taken on the under the mnemonic Socrates. Okay, and we have to look the context of the patient presenting to our emergency department as well. Talking about the site, if the patient has central chest pain, okay, that's basically it's cardiac in origin. Okay, if that's lateral type of chest pain, can be due to our pleural or musculoskeletal pain. Pleural or MSK pain basically lateral. Okay, onset, if it is sudden onset or gradual onset can be there. Okay, if there is sudden onset, then that can be due to pulmonary embolism, aortic dissection. Okay, whenever you take history, you have to put, does it fit to which of these 6 condition I told earlier. Okay, and pulmonary embolism, aortic dissection, and pneumothorax, tension pneumothorax, these are basically sudden causes. And talking about the gradual cause like pericarditis, pericardial effusion, pericarditis. Okay, anginal type of chest pain occurs when we do some exertion. Okay, exertion is gradually increase, and the patient might have less than 5 minutes of pain in stable angina, more than 5 minutes of pain, increasing type of chest pain in unstable angina. Okay, after that we have to look for the character. In MI we have heaviness or pressure sensation, heaviness or squeezing or pressure like sensation in middle of our chest. Okay, in aortic dissection, that's tearing type of chest pain, in the central of our chest, which is radiated to back. Okay, and this basically character. And radiation. Okay, talking about radiation, MI has radiating, the pain of chest pain of MI is basically central and radiating, and it radiates towards left shoulder or jaw. Okay, the pain of aortic dissection is central and it's radiates to back. Okay, and associated symptom in MI, it's associated with nausea, diaphoresis, nausea, diaphoresis, and our dyspnea. Aortic dissection, the patient might present with syncope. Okay, in pericardial effusion, patient might have the symptoms of the pericarditis, like fever or something like that. Timing, basically, if you think about MI, the patient might come within 20 minutes. Okay, after 10 minutes, after 5 to 10 minutes of chest pain, anginal pain basically subsides within 5 to 10 minutes. After that, if that's not relieved, then that patient might land in our emergency department. Exacerbating and relieving factor. Talking about exacerbating relieving factor, in case of pleuritic type of chest pain, in pericarditis, basically our chest pain get relieved when leaning forward. Okay, and our this pericarditis or any pleuritic type of chest pain, that's increased with inspiration. Okay, anginal type of chest pain increased with exertion. Severity, basically severity is we have to deal with severity with pain scale. We have to write how severe is the pain. After that, we have to know the risk factor. Okay, if a patient is more than 40, male, smoker, with hypertension, diabetes, dyslipidemia, family history of coronary artery disease, by this risk factor we can think the patient might have MI. Okay, and if there is an immobilization, surgery, malignancy, this risk factor might tell us the patient might have pulmonary embolism. If the patient with malignancy only, or then we can also think of pericardial effusion. Okay, and how to take the focus physical examination, how to examine the patient. In general examination, we look for if there is diaphoresis, pallor, anxiety. In vital patterns, this is most important. Okay, if we can think about this pattern, then our diagnosis will be easier. Okay, if there is hypotension, muffled heart sound, and increased JVP, then it can be due to cardiac tamponade. That can be due to cardiac tamponade. Okay, and if it's asymmetrical pulse or BP, it's more than 20 mm as the change in BP among two hand, two arm, then that can be due to aortic dissection. Remember, in aortic dissection, the pain is central, tearing type of chest pain that radiates to back. Okay, and if there is tachycardia and hypoxia, then you might think of pulmonary embolism or pneumothorax. Okay, pulmonary embolism. Basically, the patient with pulmonary embolism might only present with tachycardia. Okay, and pneumothorax. New murmur, like in MR, new MR can be there in MI. Okay, because of rupture of this papillary muscles or papillary muscle dysfunction. Okay, and new AR can be there in aortic dissection. Aortic dissection, the flap might reach the aortic bulb and cause aortic dissection, and in fact after it reaches the aortic bulb, it can also cause our this pericardial effusion. Okay, pericardial rub basically seen in pericarditis. Talking about respiratory system, if there is a decreased air entry, hyperresonance, then we must think of pneumothorax. If these crackles can be due to left ventricular failure or pneumonia itself, if it's localized. Okay, if there is local tenderness, we must think about costochondritis or MSK pain. After doing examination, we have to immediately rush to our investigation. And remember, this investigation we have to send within 10 to 15 minutes. Okay. First of all, ECG to rule out one of the most dangerous cardiac pain, acute coronary syndrome. Okay, there are certain patterns like ST elevation, ST depression, hyperacute T wave. Okay, these are the things we have to look in ECG to find if the patient is having MI or not. Cardiac biomarkers like troponin, if we have high sensitivity troponin, we have to send. Otherwise, we can send other troponin as well, normal troponin. Okay, troponin I as well. But remember, in 0 to 4 hours, the patient might not have raised troponin. Okay, so we must, if we have done in 0 hour or 1 hour, then we have to repeat it again in 1 hour and again in 4 hours. Okay, and chest X-ray to rule out pneumothorax or any pneumonia like things. Okay, bedside focus echo, if that's readily available, then it's very important to rule out regional wall motion abnormality to detect myocardial infarction, and if there is pericardial effusion or not, to rule out tamponade, and we can also rule out our pneumothorax. Okay, pneumothorax with focus. After that, ABG and SpO2, D-dimer and pulmonary CT angiography if there is high risks of pulmonary embolism. This is we send the patient to CT angiography after the Wells criteria. Okay, you have to calculate the Wells criteria. If it is high, then there is a chance of pulmonary embolism, and we have to send the patient to CT pulmonary angiography. Remember, you have to calculate Wells criteria before sending the patient to CT angiography. These are basically the baseline test: CBC, renal function, electrolytes. After that, we can do risk stratification ACS. Okay, validatory scores like there's heart score. We have to look about the history, ECG changes, age, risk factor, and troponin, and we basically categorize the patient into low risk to high risk. Okay, and this is the chart of heart score in the history. how is the suspicion, is it ST depression or ST deviation is there or not, according to age, risk factor, troponin normal limit. We categorize this patient, whether we need to admit this patient, whether we can dispatch this patient. Okay, and there is something called Grace score also to predict the mortality. After that, after doing history, physical examination, certain investigation, we have to categorize this patient, okay, basically into 5 category, whether it's cardiac cause, okay, non-cardiac cause, vascular cause, pulmonary cause, okay, pulmonary cause, and our GI cause. Cardiac cause like STMI and STMI unstable angina, with the pressure, with the clues of with the pressure, exertional chest pain radiating to left side, left shoulder with jaw, elevated troponin, we think of STMI or MI itself. Pericarditis or myocarditis, we might have pleuritic chest pain that is positional, that is relieved with leaning forward, and there is a diffuse ST elevation in pericarditis. In myocarditis, we have features of both pericarditis as well as myocarditis. Okay, there is raised troponin, there is increased troponin with ECG features or something like that of pericarditis. Vascular pain like aortic dissection or pulmonary embolism, we have sudden tearing. This aortic dissection have sudden tearing type of chest pain, and in pericardial effusion, D-dimer will increase. The patient might have malignancy or prolonged immobilization in pulmonary embolism. Okay, pneumothorax, the patient might have pleuritic type of chest pain, and in pneumonia, pleuritis, pneumothorax, patient should have respiratory sign. Other simple type of chest pain like GERD, esophageal spasm, costochondritis, anxiety, these are the things it's very difficult. Okay, we basically diagnose this entity after ruling out other major killers. Okay, if there are no other killers, then only we have to think about this condition. Okay, because there are no certain criteria, and the patient might die if we cannot find the killers. Okay, so what about management? So if we think the patient is having ACS, okay, acute coronary syndrome, before that, if there's a critically ill patient, okay, if the critically ill patient, always look for SpO2 and give oxygen if it's less than 90%. Always have IVIS. It's needed to push any medication we need. Cardiac monitoring is important. Cardiac monitoring, pulse oximetry, ECG monitoring. These are the things that's very important. If a patient with chest pain and ill patient, we have to do first. And if ACS is suspected with history, examination, or our lab finding, then immediately we have to give aspirin 300 mg, clopidogrel 300 mg. If there is pain and without hypotension or right ventricular infarct, if you do not suspect this, you can give nitroglycerin sublingual tablet. But if there is more pain, we can also give morphine. Okay. After that, statin, high intensity statin, atorvastatin 40 to 80 mg or rosuvastatin 20 to 40 mg. Okay, we can give either of them, and then you have to call for cardiologist for PCI or thrombolysis if that's present in your hospital. For this, if you can send that patient to PCI, okay, within 90 to 120 minutes, basically 90 minutes, then you have to send that patient for PCI. But if the patient cannot reach to within 90 minutes, then it's better to thrombolyze that patient, okay, within 30 minutes. Remember, thrombolysis should be done within 30 minutes. You have to do ECG within 10 to 15 minutes if you suspect MI, and if you can send that patient to PCI capable center within 90 minutes, then you have to send. Otherwise, you have to do thrombolysis within 30 minutes. Okay. if P is suspected from history examination, all that, we have to risk stratify the patient according to the according to the blood pressure of the patient and the RB wall. Okay, RB wall hypokinesia is there or not. If there is hypotension, that is very high risk MP. Okay, if there is hypotension, then we have to give primary therapy. Primary therapy is basically embolectomy. We have to remove that embolus if possible with a catheter or surgical embolectomy. If that is not possible, then anticoagulation plus thrombolysis should be done. Okay, but if the patient has a normotension in normal right ventricular wall, then we only give secondary prevention. Secondary prevention in pulmonary embolism is to prevent the embolus from your DVT. Okay, from your deep vein from your leg, that we prevent that embolus to go towards your pulmonary our vein. Okay, and we keep IVC filter or anticoagulation according to the risk factor present in the patient. We do secondary prevention with the normotension and normal right ventricular wall. If the patient normotension but RV hypokinesia is there, individualized therapy, either go to secondary prevention or primary therapy according to your need. After that, if you suspect aortic dissection, you have to give beta blocker first before vasodilator, and send that patient to a CTBS surgeon. Okay, if pneumothorax suspected, you do urgent needle decompression. If tension type of pneumothorax or tension pneumothorax is there, if cardiac tamponade, you need to do pericardiocentesis or send that patient to the center where pericardiocentesis is possible rapidly. Okay, after that, let's do a summary. Whenever a patient comes with your chest pain in your emergency department, rapidly do ABC, do vitals, take focus history, examine that patient. After that, do ECG, troponin, chest X-ray within 10 to 15 minutes. Okay. After that, identify or exclude 6 killers: acute coronary syndrome, pulmonary embolism, aortic dissection, pneumothorax, cardiac tamponade, and esophageal rupture, and stabilize the patient. Specific management as per diagnosis should be done, and if no life-threatening condition is identified, manage as per etiology. Like in GID, we give PPI. In MSK pain, we give NSAID. Okay. Document risk stratification and plan what you need to do this for the patient later. Okay, these are the reference I took to make this presentation. Lastly, these are the clinical pulse I must talk to you. Pain that is producible on palpation does not always rule out ischemia, but remember, if you can pinpoint the pain, then that is not ischemic. Okay, if you can pinpoint chest pain, that is not ischemic. Up to 5 to 10% of ACS have normal initial ECG. Okay, always repeat ECG within 10 to 15 to 30 minutes, and if needed, you can repeat every hour after that. Troponin elevation in MI. Troponin elevation alone is not equal to MI. Okay, there are other hundreds of causes which can increase troponin, like myocarditis, renal failure, sepsis. So history is important. Okay, pericarditis can have also certain small rise in troponin, because sometimes in pericarditis the myocardium might get involved. Okay, pulmonary embolism. These are the things you have to rule out. Never give nitrates in suspicious of RV impaction or severe AS. This will decrease your BP and patient might collapse. Always compare BP in both hand for dissection. Okay, if you suspect dissection, then you have to take BP, or otherwise you have to make a protocol to take a BP whenever patient comes with a severe type of chest pain, because we never know, the patient might have aortic dissection as well. Thank you. This much for today.